Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming.
Welcome back to New Retina Radio, Back to Practice, Telemedicine in the COVID-19 era. And today is September 11th, and I'm joined by three amazing international guests. We have Francesco Boscia, who is the Director of Ophthalmology, Director of the Ophthalmology Clinic and School of Specialization in Ophthalmology at the University of Sassari, Italy. We have David Steele, Consultant Ophthalmologist and Vitreoretinal Surgeon at the Sunderland Eye Infirmary and Honorary Professor of Retinal Surgery at the Institute of Genetic Medicine at Newcastle University in the United Kingdom, and Ramin Tadayoni, Professor of Ophthalmology at the University of Paris in Paris, France. Just to give a brief update, currently worldwide, we have 28.1 million cases of COVID-19 that are known diagnosis, 909,000 deaths. In Italy, we have 283,000 cases with 35,000 deaths. The United Kingdom have 360,000 cases of COVID with 42,000 deaths. In France, we have 392,000 cases, 31,000 deaths. And in the United States, 6.3 million cases with 191,000 deaths. With that, I'd like to welcome in my guests. Thank you all for joining us here for Back to Practice, New Retina Radio, focusing really on telemedicine. And let's start out with David Steele in the UK. David, what's the status update on COVID-19 in the United Kingdom?
Well, so we're just starting to get a significant recurrence, John, unfortunately. So the numbers have crept up, I think around about 20 per 100,000 cases, something like that in a lot of areas, and local hotspots. So parts of the UK are going down into quite intense lockdown, but there's also just nationally, there's just been announced that they're restricting social interaction. So you're not allowed to meet in groups of more than 6 with more than 2 households. So they're trying to sort of nip the recurrence in the bud. Clinically, we're carrying on as we've done before, which I'm sure we'll get on to discussing.
So David, do you attribute this recurrence to anything? Are people easing off on some of the restrictions and therefore we're seeing recurrence? Is it a back to school issue or is it a multitude of factors?
Well, schools have just gone back in the UK from last week, but actually I don't think it's that. I think it's a relaxation of attitudes. People, holidays, people were desperate to start seeing each other, and pubs were reopening in some forms. Restaurants, where there was a massive drive to get back people to restaurants. I think the increasing, mixing has led to it. It's a very difficult situation because a lot of people are very upset, but equally well, nobody wants to go back to the figures of March, April time. Yeah.
No, absolutely. Ramin, I just read an article that there are now 10,000 new cases a day in France, that this is an all-time record for France. Are you feeling that type of recurrence?
Yes, we do. Actually, the number of cases depend also on number of testers, and now more and more institutions ask people doing tests. So maybe this is not so reliable to compare to what it was before, but the number of patients coming to the hospital and with bad situation in particular, that's really an important factor. And we see again in the hospital more and more people. So actually, yes, there is an increase. Clearly, there is an increase. We hope that it will not be as bad as before because still people have some masks, people are careful. But as David explained, people also go to restaurants, young people interact, they go to pubs, bar, and cafes. So yes, there is some increase.
And Francesco, Italy was really kind of the epicenter at the beginning of this and was hit incredibly hard, but it seems like Italy is doing an amazing job now. What are the status of things in Italy?
At present, we have on average 1,500 cases per day, new cases per day. Of course, as Ramin said, not all of them are hospitalized, and I think that part of the so-called second wave of COVID cases is due also to the increased number of tests that are done today. But obviously, as has been said, there is the need for people to interact. Restriction created really a drive towards interaction and to starting again, possibly a new life. And also, as you are all aware, Italy is a vacation spot. So there was a lot of tourists coming into the southern region, to the islands, people mainly from Italy, mainland Italy, but also from abroad. So obviously there was a mix-up of cases of people that drove to this new, as we call, the second wave of cases. But as has been said, so far the situation is not as terrible as it was during March and April, when really in the northern area there was a nightmare situation.
It really was. Francesco, is your clinic back up to normal now? Is it 50% of normal? How busy are you currently?
Well, it depends. As for the retina part, we never stopped injecting patients. We never stopped seeing a new patient. Of course, there was a restriction in the access to our clinics, but still we, at least I try to keep it open and active. So we injected all the patients with CNVs. We turned the drug choice towards steroids for diabetic cases. So we try to manage according to the restricted access to the situation. So as for the retinal side, I would say we are 90% of the usual activity. As for the other side, say all the cornea part, also glaucoma, unfortunately, and other subspecialty and cataract surgery, of course, the activity at present is about 30% of normal.
Wow, so still very, very affected. And is that on the patient side, not wanting to come to the hospital, or is that more on the hospital side, limiting patient access?
It's, at present, is mainly on the hospital side. Of course, we provide access to the theater to all the patients who had their examination done beforehand. So we don't want really to spoil our theater with a possible case. So there is a restriction on that side, but also we try to keep the clinics open for really, I wouldn't say urgent, but really for patients needing assistance at present. Initially and at present, marginally, there was also a patient mindset that really, they were very cautious, and especially old patients were really cautious in approaching our clinics.
Okay, great. David, what about you? What is the update on things with your clinic now?
Yeah, so we're running at around about 70 to 80% capacity based on social distancing. So I mean, as Francesco said, we didn't really, from a retinal surgical point of view, I never really stopped because a lot of work was urgent, and we kept on injecting people. We had a large number of people who didn't come, of course, because they were self-isolating and didn't want to come to the hospital, but we offered the service for things which were urgent and time critical. And then about 2 months ago now, we started doing cataract surgery at about 60% capacity, and then we're up to, and there's a lot of pressure on us, a lot of pressure on the health service to start, eating into this enormous number of patients who have had their treatments delayed. And so I know we've got a backlog of around about 1,000 cataract patients, for example, which we're eating into, but other places have got much bigger numbers. We're actually, interestingly, working with less people because there's less people coming, because we've got a small, clinics are also restricted in capacity. So as it stands, I suspect we'll actually, our own hospital will get the sort of backlog recovered at some point in the next 6 months, but I'm not sure other places will. Yeah, so that's going to be, I mean, that's a major challenge because the NHS, is a national health service, and it is very much run on a national level. So with trying to have equity of care.
And I guess that's something that across all specialties they're having to deal with. And so it's going to be just a logistical nightmare. That's a really great point. Ramin, how are things in Italy? Are you digging out? Are you currently busy up to full capacity, or where are you at on things?
So in Paris is quite similar to what has been said. So basically, I think we are around 80% our activity, and this is due to the distancing, because you want to have no waiting time at all for the patient. You have to decrease the capacities everywhere. We reorganized many things to be able to not to decrease to half, but just to 80%. And of course, it's more important for us to treat all the emergencies, anything that could not wait. And the waiting time for things that are not emergency is increasing with time. We don't have any more significant number of patients not coming to the clinic. And even during the worst time, when it was important for the patients to come, we had a plan to call each of them. First, the secretary call, and if the patient refused or said, I need more information, the doctors call too, because the doctor usually is a little bit more convincing to explain why it's important for the patient to come. So we tried at least to be sure that nobody is going to lose vision during this situation. For things that are not emergency, many people will openly say, you have a cataract. Yes, we can do it. We have some capacity to do it, but it's not at all emergency. If you think it can wait, let's wait for next year. So this way, I think 20% of the activity has been decreased, so it has been saved for next year.
Okay. And will that put an undue burden on the health system in France, or do you feel like that's something that you have the capacity to dig out of within the next 6 to 12 months?
I think it puts some burden on the system, and we will feel it more next year, because all these patients, we say you have to wait for next year for this. So we will have to treat them, and there will be new patients. It will take years before it's fully absorbed. But again, it's very important for us to be sure that patient will not lose vision due to this. If it's just some waiting time and it's acceptable by the patient, we can wait. But even for cataract, there are patients that cannot wait. They have one eye, their vision has decreased, they cannot work, so it's important to take care of them.
And Ramin, are you delaying any retina surgeries at this point, or are you able to do all of your retina surgeries?
Right now, I would say we do all the retina surgeries. We don't delay. Yeah, I think we do everything. I was just thinking if there is a situation we can wait for 1 year, but for retina, it's not usual that if there is anything can wait so long.
So no limitation on epiretinal membranes or macular holes?
No, we do this.
Okay, fantastic. Well, the real goal of this podcast is really going to be looking at telemedicine. So I want to get into the telemedicine side of things. And we have a really unique aspect here today, because we have people who are kind of figuring out telemedicine, people who are kind of midway through telemedicine, and then people who have done a fair amount of telemedicine. Ramin for almost more than a decade. So Francesco, I will start out with you. Tell me about your experience right now with telemedicine.
Yes, unfortunately, we are very primitive in our telemedicine approach. And this is due to the, of course, lack of hardware, lack of connections. The national system in Italy is a burden of debt, and telemedicine was perceived as being a luxury. And this was true till before the COVID era. Now, of course, there is a different awareness. But at present, still, we are at that stage. So what we can say about telemedicine in our, at least in my hospital, is that we started utilizing telephone calls, of course, to assume patient that missed visit, in order to understand whether this was due to the patient perceived difficulty in coming, or because of any other reason. And as Ramin said, initially this approach was done by nurses or by administrative clerk, and in more difficult cases or cases where we really perceived there was the necessity for the patient to be seen soon, a doctor, usually a resident, try to convince the patient to come over. Apart from that, we also shared few examinations, mainly OCTs, of course, with the say peripheral doctors, spokes doctors, who shared with our clinic the images and the patient cases, and we discussed with them the urgency or the possibility of delaying seeing or treating this patient. And this was done by texting, so very primitive, unfortunately. Now I think that there will be a massive inflow of funds, of course, by the national system, because the new medicine approach needs definitely telemedicine, at least for some patients. I wouldn't say this sometimes, most of the times, patients still need the doctor contact. And also our decision, and this is my perception, but I think that my decision would be different if I was in front of the real patient and all the investigation and the relatives around to discuss the patient management.
And go in a little more depth in that, Francesco. How do you feel like you would change things if you're not in person with the patient? Are you less likely to treat that patient because they're not there? What would you do differently via telemedicine as far as your approach to the patient?
But as I said, I don't think that is just a one-way change in the attitude. I think that discussing with the patient sometimes make you treat the patient you might have decided otherwise and the opposite. So it's really the interaction with the patient, his examination, the biomicroscopic appearance, which is undoubtedly different from all the OCTs or investigation, and also the relatives. And sometimes made me change my attitude. I understood this already in the past. When I was looking at the patient notes, I decided for some approach, surgical or treatment approach, but I changed my mind when I was in front of the patient. I was surprised by that. So I don't think really telemedicine can substitute.
You know, Francesco, that's a really astute point I never had thought of. It's really about that emotional intelligence and feeling that patient's body language, their reaction to your discussing the condition, the treatment options, that tells you so much. You know, you can see a patient, you say, you're going to need an injection in the eye, and you can almost feel them retract. And you think, okay, I need to overcome this obstacle of the fear of injection. And I do agree, you lose some of that. You lose seeing the patient's family out of the corner of your eye and how they are responding to what you're saying, either in a supportive or a questioning fashion. So that's really, really key and insightful, that telemedicine cannot transmit many of those things. David, you are kind of midway through the telemedicine. You guys do some telemedicine screening for diabetes and diabetic retinopathy. You're using some telemedicine, but have found some obstacles. Tell us how you are utilizing it.
Yeah, just to pick up just briefly on what Francesco was saying, and I completely agree. I mean, so the UK, you know, has had a drive for things like diabetic retinopathy screening and follow-up of patients with diabetic retinopathy for a long time, because basically we haven't got enough eye doctors to actually see the patients. And it is interesting. So if you ask a patient, you know, and the drive has been basically to make sure that the doctors are seeing appropriate patients. They're not seeing patients they don't need to see. But if you ask a patient what do they want to do? They want to see an expert. They want to see an expert in their subject, even if they haven't got anything which is sight threatening. They want to know what really is. And so there's this clash between, you know, what we need for terms of health service provision. And of course, this is relevant in terms of COVID. You know, patients still, some of them will want to still come and so on, and some of them won't want to have telemedicine. And also the surgery in particular, you know, if you're going to operate on somebody's eye, even more than intravitreal injections, they've got to trust you, and they've got to know that you're going to do a good job. And on telemedicine, that's really difficult to come across. Yeah, so sorry, that was just that's a pick up.
It's very accurate as far as that goes. So how are you guys adopting telemedicine, and what have been some of your obstacles?
Yeah, so we've had so for a long time set up our program 21 years ago for diabetic retinopathy screening. But what we've done basically with the COVID pandemic is decided to extend that in a very major way. So we've already had a thing called digital surveillance for a while, where we follow up people with more than referable retinopathy, but less than treatable. And now we've decided to put everybody who isn't needing active treatment into the follow-up system. So loads of people who've had treatment, loads of people who have got maculopathy, but they're below treatment thresholds, and we follow them up now on short intervals in the community with OCT and wide field photography. And then we have a team of graders who aren't ophthalmologists who grade those images and only send in the ones that need treatment. But that team is very closely linked in with the ophthalmology team. So so myself and my colleague Mr. Majid Habib are the local leads, and we were very linked in with that. So that's to try and reduce people's exposure and only make them come to the hospital when they need it. So that's established and now expanding and fulfilling that role. We just again to pick up on something we mentioned before, we do a treat and extend injection program. So we did consider using telemedicine for injection patients, but basically we always inject when we see based on treat and extend. We've had an OCT virtual service for a while where people who have post-injection, in the post-injection phase, being followed up can get OCTs virtually, and we still do that. I mean, one of the problems, of course, is with, if you contrast us to dermatologists where they can take a picture, we need a fundal picture or an OCT, and the technology is more exotic, and although it's expanding into optometry services in the UK, it's not readily accessible, and the systems, as Francesco said, aren't linked. So our diabetic retinopathy system is completely linked into the hospital, but the optometrist systems aren't. When we do one other thing, which I think is good. So anybody with what we call acute maculopathy, which could be it's typically wet AMD. It could be a macular hole, could be macular pucker, could be a retinal vein occlusion, etc., etc. We have a virtual assessment where we get them up, image them, check their vision, and then we phone them with the results of the imaging and discuss it. And that way we can prioritize patients into so we can actually get a large number of photographs, phone them, but actually only see a lesser number in the flesh to reduce because we've got less appointments, and that's working pretty well.
Gotcha. And back to the diabetic screening, as far as that goes, your diabetic follow-up, it sounds like you've had a real influx in patients now that you're actually judging some of those treatment patients that have to come in. How important is ultra wide field photography for following our diabetics? Yeah,
I mean, so I kind of lied basically. We do fields. We do fields in the periphery, but we don't have wide field cameras in screening. We've got wide field cameras in the hospital, and it's a really important topic. Because myself and colleagues have published on wide field photography versus local photography for picking up new vessels, and there's a big study just finished in the UK led by Naomi Lewis called the Emerald Study. It's just in the process of revisions in ophthalmology, which is looking at the follow-up of treated patients with wide field photography. And basically that is cost effective. And I'm sure in the UK that will come in a major way. Again, whether the patients want that, I'm not sure, but the UK, aside from COVID, we already had a big capacity problem, and now we've got an even bigger capacity problem. So it's not, I'd love to say it was a choice, but it's not. We're going to have to go to those sort of measures.
And how do you communicate with those patients when you're reviewing their images? Do they get a letter? Does someone call them?
So for a lot of the diabetic retinopathy stuff, it's a letter, which is not ideal. For the acute macular patients I referred to, we phone them and speak to them in person, because usually that's a new diagnosis. It's obviously quite a complex thing. and you're speaking about, sometimes you're saying, okay, look, we're not going to see you, but we're going to re-image you in a certain number of time. And you have to have, discussion regarding that. But actually, interestingly, the diabetic retinopathy stuff works quite well with letters, I guess because they've often been in the system for a long time. We also have, the staff are very trained in terms of, look, you wrote, reassuring them that they don't need treatment. So they are seen in person when they have their pictures taken. And unlike a lot of places, we actually do live grading a lot of the time. Not for all cases. Some cases they won't be sure what to tell the patient, but a lot of the time they're live graded. So the patients will be told that they're okay in person, which is, it's much more acceptable, I think.
So your graders are right there on site where the patient's having the photography done. That's interesting. So they can come out and say, here's what's going on.
Yeah, not all the time, because some grading need more time and more experience, but a lot of the patients, yeah.
How long did it take you to get your graders up to speed? Is that an intensive program? What kind of qualifications do they need?
Yeah, so that's a long story, but effectively in the UK now it's quite structured. There's a series of qualifications from the most basic sort of photography skills up to grading skills, into advanced grading skills with OCT. And there's a series of qualifications the team can get, and they progress through various layers. And for the very advanced graders, they also have to have a very rigid quality assurance scheme where they have to do parallel clinics to actually to make the quality assurance meaningful in our system, at least for this advanced people who've been treated grading. And I'm pretty confident. We've got a lot of very experienced graders. So it's a big structure. So when somebody completely new comes in, they work their way through the series, and to get them to be an advanced grader will take several years, a long time. But it's quite an organized structure, and that's taken a long time to reach the point that it is in the UK, which is interesting in terms of AI, which I know Ramin's got some experience of. The national screening program in the UK is considering AI. But because it's a national screening program, we can't institute it locally until it's accepted nationally.
That's quite interesting, and a great segue. I was thinking the same thing. I mean, tell us about AI and grading of diabetic retinopathy in fundus photos.
So inspired by the British experience on the screening of diabetic retinopathy, years ago, my former chief of department began a screening program in France, because basically 2/3 of the patients never go to the ophthalmologist. They didn't have access for any reason because it was difficult and so on. So we had for more than a decade a huge database of images, well graded twice by people who are checked for the quality and so on. And later on, our problem was to find grader, because for legal reasons in France, it has to be done by an ophthalmologist. We can't train someone else to do it, and it's very difficult to find ophthalmologists doing this. So years ago, again, in the department, even before I became the chief of department, there was a program to try to find an AI system. And they had been tentative with different technologies until these last neuronal networks came out, and this one was very effective. And it happens that it's as effective as grader to make screening for most of the cases. So this has been developed. Now there is a CE mark FRCOphth system, which is based on this and is available for European right now. And in a few seconds, it makes the screening, and we have checked several times that it's working well. So it solved the other piece of the puzzle, which is who is going to grade it. So of course, it has to be tested in different settings because any aspect change. And I find in telemedicine, because this is not our only telemedicine program, we have a few ones that we begin, one of them 5 years ago when I become chief of department for other diseases. So we are very conscious that we have to make the life easy for the patient. But what I learned very quickly is that this is very different for tech development. Tech people develop gadgets that work somehow, and then they improve it with time because we use it and they improve the tech. In medicine, you can't come with something, say, oh, it works, so and we are going to improve it if there is time later on. So you have to be sure that it's secure. And any small aspects from the network, the quality of the imaging, the doctors, the patient being here or not, the selection of patient, everything has an influence. And recently we did something about this in one of our clinics, which is We basically make the images with the patient. We had the patient in front of us. And a few weeks later, we asked the same doctor to review the file. He didn't remember exactly which patient was. It was mixed, and make an assessment what they want to do with this patient. Very simple question, treat and extend. Increase by 2 weeks or decrease by 2 weeks. And we find in 1/3 of the cases, there was differences between the real and these semi-virtual things. And so it's very complex. And myself, we have something similar to what David said that we begin after the pandemic, basically, which is the imaging clinic plus teleconsultation. The patient comes, have images immediately with no waiting time, go home, I call them and say, I am in the file and the images in front of me. Selected patient, not everyone going this. And still, I found it very challenging, very difficult to solve the problem on phone compared to having the patient in front or asking from one extra imaging because I want something precise. And in many cases, you have to say, okay, at the end, please come back because it's too complex. So telemedicine is not just a technology problem. We have to solve all the problem around, test it, be sure that it's working. It's like the vaccine issues. Everyone wants a vaccine, but you can't go quickly. This is human health is important thing. So we have to be careful.
Very insightful. So you said 1/3 of the time doctors would disagree when they were looking at the images virtually. What are some of the common causes of that disagreement? Is it not being able to get additional studies, or what sorts of things lead to that disagreement?
So honestly, we are looking to this right now. So I don't have the final result of this, but looking to them, basically my feeling was that what they decided just based on imaging was the right decision. But what decided with the patient is the pragmatic decision.
That's really amazing. So you think there may be some influence from the patient that affects the doctor and makes them choose something that may not be the best thing for the patient?
I do think, usually you don't put the patient in danger. That's not the issue. But one example, so the patient, you think you can increase by 2 weeks the interval, which is good for the patient because they have a larger interval between injection. And for any reason, the patient at the time you want to have the injection cannot come, another medical consultation or holiday, whatever, important commitment. And you just adapt, say, okay, we'll try this next time. So no safety issues here, but you just adapt to real life of the patient. Okay. Basically, we try this. When you adapt to the real life of the patient, you improve the result because you have to be adapted and be pragmatic. So this is still something that we have to solve in telemedicine.
So, Ramin, you've got so much experience with telemedicine. How are you using it in the view of COVID?
So basically, we increase some of these programs, but under control. So some of them, for example, for this imaging and teleconsultation later on, instead of putting just technician doing the images, we put a resident who have some experience, saying that if you see something really awkward, just let us know and we will take, so this is extra security issues by the time. But we use it to evaluate to see if we can go further with more and less success. Sometimes it's so difficult to have doctors and patients be used to such a system. They don't really understand why I am not, for example, what I said, the doctor will call you. So why the doctor is not here? So I want to see him right now. Why he's going to call me? So of course they prefer that you do everything just for one of them, but we are conscious that we have hundreds of them to see in the same day. And we find here again a pragmatic decision between what we can offer to each of them and how we can treat all of them.
That's very interesting. Are there barriers to communication when you call an older patient?
A lot of them. I mean, so some of them just don't answer the phone when you are supposed to do it, and you have to call them later. Some of them have hearing issues. I mean, it's quite common to have a presbyacousia too with AMD, and they have hearing issues. So we have really to select patients for this. So it's not always easy. And they don't understand, not all of them like this. We make a survey about the virtual clinic. Basically, we send the patient do you want to see the doctor? Would you accept to see the doctor, not to see the doctor, by having a more speedy process? You don't wait at all. So 1/3 of the patient, they say, I don't mind. As far as it's quick, I prefer not to see the doctor. It's not one issue. 1/3 say, I want to see the doctor all the time. And 1/3 prefer the option in which they see the doctor time by time. And actually, that's my preferred one, is that you don't see the doctor for 3 times, and the 4th time you see the doctor to have a communication. Someone at some point should check that everything is okay. Otherwise, the system could become crazy.
Absolutely.
It's really interesting, actually, John. You know, because this sort of relationship thing is really interesting, because it's the same with friends. So it's been shown that basically, so it's the same with, and you'll notice it with teleconferences. If you know people in a teleconference, I've met you all you 3 guys. If we haven't met before, the relationship would be totally different. And it's the same with patients. If you once you've met them, you have a very different relationship. But to maintain that, you have to see them occasionally. So to go back to the point, you can miss a couple of ones, and you're on the phone, it'll be great. But if you miss them for more than a year, you'll probably be back to almost square one. The trust won't be there. And medicine's an art, isn't it? It's not a science. And it's totally different from tech. It's an art. And it's just very nicely.
John, sorry to interrupt you. I just came to my mind that one of the main issues in interacting with old people is that sometimes they deny having been called, they deny having been in favor of some treatment or investigation. So it raises also a medical legal issue, because you know, these people, I mean, it occurs to, I think, to any of us that even if we discuss with the patient, explain, have them sign in front of you the consent, sometimes they deny at least having understood correctly what has been said. So I think that with this, say, more different way of communicating, this also might be a problem, at least in our country.
You're absolutely right, Francesco. Do you think that not seeing patients in person could lead to increased physician burnout? I mean, do you lose some of the joy when you interact with patients like this versus seeing them in person?
I think definitely yes. And also I wanted to say something about what Ramin said, you know, about the agreement among colleagues. Sometimes when I visit, I have some other, either resident or another colleague with me, and we discuss and we interact. And I wouldn't say most of the time, but sometimes we are not in agreement. So I don't think that the agreement is between the machine or the investigation and the physician. I think that the agreement is between or among doctors. So, you know, a joy of seeing patients, discussing cases, you know, we used to say a couple of brain is better than one. And I think this is really the case. Also, when it deals with the joy, with the enjoyment we, all of us experience when we are in contact with our patient.
So Francesco, with that in mind, do you think that telemedicine is something that is going to survive and thrive post-COVID? Or do you think once COVID is over, we go back to our normal standards?
I think that some of it will stay, definitely yes. To be honest, I don't think that, I mean, the acute maculopathy, as David named, those will stay as telemedicine cases. I think they will come to our casualty department. So I don't think that for that side, telemedicine will survive, but definitely for the screening and for follow-up of diabetics, more chronic cases, also glaucoma cases, part of it will stay. Still, we have to improve something. I don't think that still we have accurate home testing or cameras, because I mean, definitely, even with this telemedicine approach, someone should take pictures of the wide angle fundus images or OCTs. There is a person in front of the patient. So what I really think telemedicine should do is to have a sort of two-way relationship. So the patient can test visual acuity, can have the pictures of the images taken, and the doctors can see. Otherwise, there still will be a third party in this relationship. So again, accurate home testing, improved cameras or devices to acquire images, and a good connectivity are the future. If we want this to be transferred also in the future.
David, a similar question. Is this going to be something that COVID is a launching point for telemedicine? And if it is, as Francesco alluded to, what is it going to take for us to make that next step?
Well, it may be. I think it needs integration of care, which is going to take a lot of resources. You know, the UK has been through this before with GPs. GPs are now integrated into care, but they weren't 10 years ago. And optometrists are now need to be integrated into care. And that's going to be, because they've all got different machines and different web access and so on. I think the other barrier, so that's one barrier. You know, the other barrier is we haven't touched on is the time taken for these things. So in actual fact, telemedicine is not a time saver. It actually takes more time because the patient, if they have the imaging, then they have to wait in at a certain time. We have to be available to call them at a certain time because, as you say, if you call at a different time, they're often not in naturally because they're doing other things. And then you've got to spend the time speaking on the phone. You've got to document it very carefully, as Francesco pointed out, you know, for medical legal reasons. And then they still work. The general feeling is that when you ask patients, you know, sometimes they will want telemedicine, but sometimes they want to see a face, they want to see a human. So I think there may be components, but there's a lot of barriers, and not least of which, of course, which we haven't talked about, is funding. Telemedicine's there's not a funding framework in the UK, at least for this. It's done for free, essentially. So, and that can't go on.
That's a huge point, David. And also in the United States, we have issues with that as well. The telemedicine screening images and the time taken are just trying to be, it's like a square peg trying to be pushed into a round hole. We need a unique carve out that allows it to be funded. It's particularly for some of the devices like the wide field cameras, home OCTs and things like that. Ramin, do you think this is the launch of the telemedicine era, or do you think we're going to pull back once COVID-19 is over?
Something in between. I think telemedicine began before this COVID. Everyone was sensitive to this. So we are in a Zoom webinar. It exists for half a decade. Nobody used it. Now we use it. And once the COVID is finished, I'm sure we will continue to use it. Not instead of the Congress, because I want to see Francesco and David in real, have a coffee, let's say this, the coffee together. But still, sometimes if we can't see each other in the Congress, we will use this to have a quick interaction. So same for this. And I think what David said, the funding issue is a very important issue in the two sides. The first is how the insurances and the payers will agree to pay for this. And of course, they will need new data to show that it's as effective, as good. And that's good, that's fair. So it will take time. So it's not like the COVID ended and we are going to do all the telemedicine stuff immediately. It will take maybe a decade to have all the data. But at the same time, my concern or my thought is that at some point, many of the human interactions that we are talking about will be sacrificed. Because at some point, we will say to the patient, okay, I understand that for screening of your diabetic retinopathy, you prefer to have Dr. X or Y or Z to see them because he or she very sympathetic and so and so, but screening program by AI system half the price. So I just reimburse half this price and you pay for your extra yourself. And at this point, we may notice that 1/3 of the patients have no issue. They say, I love David, I love Francesco, I'm going to pay the extra and I will see them. And some of the patients, because they cannot afford it, or because they don't value it at this point, they will say, okay, Ramin, no, he's not a very good guy. I'm okay not seeing him. He's not good looking enough, and I'm okay to just have the telemedicine. So the funding at the beginning could be an obstacle, and at the end could be the drive, the killer, who will say, okay, we go telemedicine, it's cheaper. If it's cheaper, we'll see, because David say it's not obvious everywhere that it's going to be cheaper. Our ophthalmology devices are expensive. You can't have them everywhere, the best one. So diabetic retinopathy, still the screening is based on last century technology everywhere because it's cheap. You have to see.
You know, that's a great point, though, Ramin, that this could actually decrease our reimbursement. And I don't think we're actually thinking of that. If they say, hey, look, more efficient, you're not seeing the patient in person, less time spent in your clinic, we're going to decrease the work-related value of what you do and pay you less to do the same amount of work, maybe even requiring more effort, because talking to a patient over a teleconference or on the phone is much more difficult than in person.
I agree.
Last question as we wrap up here. This has been fantastic. I appreciate so many diverse opinions and so much wise insight. Ramin, what are we going to need from industry to help us with telemedicine?
Basically, to be able to run, fund, and help us running and funding clinical research showing the benefit in every aspect. I think we have to work all together, not industry alone, not us alone, not the funding or government alone. Work together with no prerequisite, with no prejudice. We just see what's useful, we take it. What's too expensive or not useful, we just accept to stop it. We have to work together.
And David, how do we get different countries, European Union, United States, you know, the UK, to all kind of come together to adopt a similar protocol? Can we do that, or is that just an immense obstacle?
Yeah, I was just thinking when Ramin was speaking there, the complexity of the trials that we're going to need to actually to answer the questions he's just posed it's complex. But you know, and obviously the funding structure in every country is so different, and it's totally different between our 4 countries. But the questions are probably similar. So it should be possible, but it'll take some careful planning. And it is in the interests of industry. Obviously, they have therapies that work and that they want us to use and we want to use. So yeah, it should definitely be a partnership to do the trials together. Definitely, yeah, challenging but.
And Francesco, I'm going to change it up a little bit for the last question with you. Italy has come through the storm of COVID and done really well. We are currently in the States, just in the midst of things. We have 40 to 50,000 new cases a day, and unfortunately are leading the world in number of COVID cases. And we're seeing a recurrence in UK, a recurrence in France. What advice do you have as someone from Italy who has weathered this and done rather well to us coming through this and getting back to a more normal life?
Well, it's very difficult because, of course, there are differences among the countries. I think that most of the cases in Italy, and the cluster of cases in northern Italy, was due to the crowding of people. I mean, the big industrial cities like Milan, Bergamo, Brescia, where most of the industries in Italy are, together with the public transport, because I think that, I mean, the metro and all the crowding within those means of transportation made a really difference. So it's very difficult, for example, for a city like New York City to move otherwise utilizing cars like we do routinely, or with motorbike, because of weather, because of the difficulties and the differences in the attitude. And these are very difficult to suggest and to give, because again, there are different structures of the cities of the country. But I think that what really made a difference in Italy was the lockdown period, and which created an awareness that social distancing and use of masks was really, and possibly gloves, was really something necessary. So I think this is something that anywhere could be done and could be improved.
Fantastic. That's great advice and gives us hope that if we can do the right thing, we can come through this. I want to thank all the panelists, Francesco, Ramin, David, you guys have been wonderful. I need to update. Francesco is actually a professor of ophthalmology at the University of Bari, one of my favorite places that I've been. I was at a meeting there a couple years ago, Francesco, and it was fantastic. Thank you all for joining us for this episode of New Retina Radio COVID-19 Back to Practice, focusing on telemedicine. I'm John Kitchens from Retina Associates of Kentucky, and tune in the next few weeks for our next episode. Thank you.
Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming. This webcast podcast is intended solely for ophthalmic healthcare professionals and ophthalmic industry representatives. By accessing this webcast podcast, I acknowledge that Bryn Mawr Communications LLC, herein BMC, along with any all third-party corporate supporters of this webcast podcast, makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information presented in this webcast podcast. BMC, along with any all third-party corporate supporters of this webcast podcast, do not endorse, approve, recommend, or certify any of the opinions or information presented or mentioned. BMC expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or other damages arising out of any individual's use of, reference to, reliance on in this webcast podcast.